Welcome, everyone. My name is Dr. Robert Coleman, and I'm a gynecologic oncologist and the Chief Scientific Officer for U.S. Oncology Research here in the Woodlands, Texas, Houston area. And I'm going to be speaking to you today about an emerging therapeutic landscape for advanced endometrial, recurrent endometrial cancer. It's a great pleasure to join you. These are my disclosures. So today I thought we would walk through some of the really developing and emerging new therapies for this disease, which has almost had a little bit of a renaissance in recent years with the discovery of new therapeutic and actionable targets. I'll walk through some endocrine therapy. We'll talk about chemo. We'll talk about what we know about the molecular annotation of this disease, how immunotherapy has become now part of our standards, and other key and emerging targets. So it's not a surprise to many, I would assume, that endocrine therapy was one of the very first types of therapy that was used to target endometrial cancer. We know the hormonal axis and how that hormonal axis contributes to the development and regulation of the menstrual cycle and development of endometrial cancer. And some of the very first hormones that were used for the treatment of endometrial cancer were targeting these factors, both estrogen and progesterone. And you can see here on the right that there's a large number of agents that have been used over the years. And most of them have at least some form of objective response. And we've done multiple trials in this space. And we've learned that, for instance, those that come in IV PrEP are not any different than oral. Progesterone and anti-estrogen seem to have a similar degree of efficacy. High dose doesn't appear to induce a larger number of responses. We do think that there may be some benefit to this alternating schedule between anti-estrogen and progesterone agonists. This has been developed in a number of different trials, including GOG 153. The response rates, the PFS expectations, and overall survival expectations are pretty consistent, as you can see there. And in general, we feel that these hormones are active, particularly among the endometrioid adenocarcinoma cohort. Now, what we've come to learn is that this endocrine axis has become much more complicated and is better defined now, particularly since the hormone axis is being used in a number of other solid tumors, such as breast cancer and prostate cancer. And we're learning a lot more of how the estrogen and progesterone pathways are activated and how they're regulated. And you can see here on the cartoon on the left, you can see the number of pathways which can influence whether or not endocrine therapy will be active, or how endocrine therapy can be overcome as a resistance mechanism. So you can see these very important pathways such as PI3 kinase pathway and MAP kinase pathway and CDK. And we're going to talk about all of those today because these are actionable targets now that with our current portfolio of drugs, which are matched with relatively high rates of overexpression, mutation, and alteration, as you can see on the right-hand side, between both endometrioid and non-endometrioid cancers. So it makes a lot of sense to look at these drugs now through a new lens with the development of overcoming endocrine resistance with combinations. Now, one of the first targets that we went after was looking at the mTOR pathway, which is at the bottom of the PI3 kinase pathway, AKT pathway. And you can see here, this is some work that we did with a single agent of everolimus in patients with metastatic endometrial cancer. And you can see that we did see some not large number of responses as a single agent, but when we combined it with hormonal therapy, we started to see some responses. And this led to the development of a trial that was run through the GOG that we hope to report very soon, but have presented GOG 3007, which was looking at everolimus letrozole versus the GOG standard of endocrine therapy, which is the alternating treatment of tamoxifen and medroxyprogesterone acetate. And what we showed in this study was that the both PFS and you can see the OS curves are listed here. First of all, the response rates were very similar between the two arms. The clinical benefit rate was slightly higher for the everolimus letrozole. But when we look at PFS and overall survival, we started to see some separation in the curves, and we thought this looked pretty good. We've gone further to annotate this by those that are chemo naive versus chemo prior exposed. And a large proportion of this benefit is actually coming from the patients that are chemo naive. What's interesting is that the response rate we saw in the chemo naive population course, these are endometrioid, largely endometrioid tumors, was rivaling that of chemotherapy. And it's raised the question as to whether or not this could be another approach to first-line metastatic and endometrial cancer as an alternative to chemotherapy. Now, chemotherapy has been the mainstay for endometrial cancer treatment for decades. I've listed these just by class of drugs. And you can see over on the far right-hand side what the anticipated objective response rates have been through these largely single-agent phase 2 trials. Now, the GOG was responsible for doing a large amount of this work, particularly in the way of randomized trials, to try to sort out which of these regimens might be most efficacious. And as you can see, the top three, the anthracyclines, the taxanes, and the platinums, really became the kind of the mainstay for this development plan. And I've listed out a grid here of how these trials were advanced over a series of about 3.5 decades. And you can see some of the very first trials was looking in the pre-platinum area of looking at anthracycline, so adriamycin here, versus adriamycin and cyclophosphamide, in this randomized study. And you can see that as one of these regimens was carried on to another trial, the next was to look at this in the platinum era, GOG 107, which compared to Adria to Adria Platinum. The Adria Platinum seemed to be more active, albeit with some slightly more toxicity. It was then compared against the anthracycline combinations, and these were walked down. You can see the addition of paclitaxel, then ultimately the triplet, and then most recently looking at the substitution of carboplatin for cisplatin versus TAP. And fortunately, this particular trial has been done for some time. I think about 8 years ago, we first saw the results of this, but here you can see the regimen of the three-drug anthracycline, platinum, and paclitaxel regimen with GCSF support compared to paclitaxel carboplatin. This trial is quite large. It was expanded to include non-measurable disease, but ultimately was reported just recently in the Journal of Clinical Oncology. Now, we knew very early on that TAP could be a fairly toxic regimen. You can see these light blue bars represent the areas that there was significant increase in toxicity. So much of the mild suppression and non-hematologic toxicities were found in the three-drug regimen. Interestingly, there was a little bit lower rates of neutropenia, but remember that TAP was associated with bone marrow support for the mild suppression. You can see the complicated neutropenia was no different between the arms, and more patients ultimately completed their planned 7 cycles of chemotherapy. These are finally the curves that we have long awaited. You can see there was no difference in both progression-free and overall survival for these two strategies. And with this in mind, this helped us to basically confirm what we're already doing, which is the substitution for paclitaxel carboplatin for standard of care for the treatment of advanced and metastatic endometrial cancer. In this trial, we also looked at patients who had measurable versus non-measurable. Remember, the trial was kept open to gather more data on the non-measurable patients. That is these top two curves, these brown and green curves above. And you can see once again that these is a prognostically better group, but no better in terms of therapeutic value between the two arms. And again, the large number of subgroups that were evaluated, essentially showing very much the same outcome across all these different subgroups. So with that as a backbone, we spent a fair amount of time trying to determine whether or not we can improve upon this. GOG 86P was looking at a couple different questions. One was to add bevacizumab to this backbone. The second was to look at an opothlone as a substitute for paclitaxel, and then third to look at the addition of an mTOR inhibitor instead of an anti-angiogenesis drug. And this trial was a randomized phase 2 and was looked at against a historical control, which is in the hard to see but black You can see it says reference PC. This is the reference paclitaxel carboplatin in the background. You can see it better over in the overall survival, but this is progression-free and overall survival. And ultimately, with these hazard ratios, you can see that there's no significant difference between any of these arms. But there's this interesting trend in the overall survival for the paclitaxel carboplatin bevacizumab arm, which was, again, of interest, hypothesis generating, but no difference in the immediate treatment effect for bevacizumab or for temsirolimus. Now, the MITO-N2 is a larger trial that's looking specifically at the role of bevacizumab in this same patient population. This was a randomized phase 2 trial, and you can see both on the at the top, looking at progression-free and overall survival, that there is a slight benefit. You can see the hazard ratio is at 0.85 for in this 100 patient or so trial, denoting a slight difference at the medians of about 3.5 months. Again, hypothesis generating as a randomized phase 2 trial, but does show some evidence that maybe bevacizumab is contributing to the overall response in this cohort of patients. Now, GOG 286B was another attempt at trying to expand upon the paclitaxel carboplatin backbone. Here we're using metformin. Metformin has activity in a number of different ways outside of glycemic control, but also evaluating the TSC complex in the PI3 kinase pathway. This has some regulation at the level of AKT. And this particular trial was used in chemo-naive patients, stage 3 to 4B. Again, a randomized phase 2 with a plan to go to phase 3 with activity, adding metformin during chemotherapy and during the maintenance phase. And this trial basically showed, after the enrollment of about 320 patients or so, that there was no difference in progression-free survival or overall survival for this particular pathway. So lots of different interesting concepts that will be coming from this as we look further into regulation of this pathway by this drug. But at least on the face value, we did not see a major difference between those two. So if you think about all of the strategies that have been done so far, using chemotherapy as a backbone, we kind of have reached a very consistent level of activity with response rates, PFS and OS being relatively consistent in the patients who have progressed following these class of drugs. So the second line agents, again, response rates, PFS and OS, very consistent. So we've kind of reached like a glass ceiling. Like we think we can do so much better, but we've kind of been basically stuck here. So fortunately, during the time that a lot of these trials were done, we did a deep dive into the molecular biology of endometrial cancer. This is the findings you guys have seen probably frequently from the TCGA, identifying the different characteristics of endometrial cancer. And you can see they've been broken down into a number of different categories. This is one that many people like to use. There's the POL-E and ultramutated, the MSI high hypermutated, the copy number low endometrioid, and the very much ovarian looking like serous or copy number high serous-like carcinomas. And you can see how these tumors are differentiated by their mutational burden. They're differentiated by P53 mutation and P10 alterations. And you can see that they're also slightly differentiated by their grade. So this has become a very important resource as we've started to look at ways to develop, the most important of which most recently has been the identification of how alteration in the microsatellite and mismatch repair genes, which are frequently mutated in endometrial cancer, have on the immune profile of these tumors. And I've put down two of these categories, the MSI high or the deficient MMR tumors and those that have high tumor mutational burden. I mentioned these are two classes of drug. There is some overlap, which I'll show you. But both of these particular situations lead to higher levels of tumor-specific neoantigens, which can then be presented to APCs, which can educate the T cells and allow for tumor control. Now, this pathway has already been well documented in tumor types that have been frequently characterized by MSI, such as colorectal cancer. But it's important to know that the frequency of MMR deficiency in endometrial cancer rivals that of colorectal cancer, and is this and endometrial cancer being a solid tumor that results in the Lynch syndrome as frequently as colon cancer. So this is a very important pathway for us to make sure that we're aware of, and during our very early evaluation of this disease, and in many situations, pathology reports are presented with an analysis of microsatellite instability. So there's been a number of drugs now that have entered into the endometrial space for trial development. I've listed them here. There's 5 of them, but it continues to expand as more immune checkpoint inhibitors bridge the network between other solid tumors where there's been activity and into endometrial cancer. The drug that probably has the most activity, or the most clinical activity, is Pembrolizumab. This has been around the longest, and it was demonstrated in a very large trial called Keynote 158, which looked at a number of different tumor types. But in 2 of these cohorts, they had patients with MSI high tumors, especially those that had endometrial cancer. And you can see the dosage is standard 200 milligrams Q3 weeks. In the endometrial cancer MSI high patient population, you can see that a large number of these patients responded. Response rate over 57%, with a large number of an important number of complete responses. Really importantly, the duration of response was not reached at the median, with 90% of patients essentially not having a progression amongst this responding group at a year. Very, very important finding, and very surprising when you look at this in the context of other drugs that have been studied in this section. And I showed you that at the beginning with respect to both hormonal therapy and chemotherapy. The adverse event profile for this in this patient population was consistent with this disease, with this drug and many other diseases, with autoimmune factors being identified, but of low frequency. And this has been our experience. In May of 2017, this pembrolizumab was approved for solid tumors that were characterized by microsatellite instability high or mismatch repair deficient tumors, which included obviously endometrial cancer. And so this has been around and has been ongoing. Now, I mentioned that in the TCGA that there was a small cohort of hypermutated tumors, and hypermutated tumors in MSI have some overlap. They don't have complete overlap, but you can see here these green and blue circles represent the population of microsatellite instability tumors in green, and in blue, the tumor mutational burden tumors. What's interesting is that many people are quick to try to identify that PD-L1 and PD-1 expression is associated with activity to immune checkpoint inhibitors. But if you limit that response to the patients that are clearly defined by TMB and MSI, you can see that there's not a lot of overlap. And so this may be why this has not panned out to be a great biomarker for endometrial cancer response as opposed to some of the other solid tumors. So, but having seen the efficacy in the high TMB space, pembrolizumab did get an approval from the FDA for TMB high, greater than 10 megabytes, mutations per megabase, which came in June of last year. So now moving on to some of the other drugs, Garnet was looking at dostarlimab in 2 cohorts of patients, those that were MR deficient in mismatch repair and those that were proficient. You can see the cohorts are listed here, 126 patients for the deficient, 145 patients for the proficient. And we had seen some early data on the proficient cohort, which demonstrated a response rate that was over 20%, which was quite unusual because it was definitely outside of what we've seen with some of the other treatment trials with immune checkpoint inhibitors. At ESMO this year, we got to see data on the mismatch repair deficient cohort, and it showed a very similar response rate to what we've seen with other immune checkpoint inhibitors in this kind of cohort of patients, a 42% objective response with a very long duration of response. Again, here, median not being reached, with a large number of patients having disease control for several months. You can see the waterfall plot on the right-hand side. When we put these two cohorts up together, you can see that now with larger number of sample that the MMR proficient category, we start to see a response rate that's more aligned with what we'd seen in other immune checkpoint inhibitors in MMR proficient cases over here in this around 13%. But you can see in both cohorts having at least some response, and you can see what that clinical activity is. Now, avelumab is another PD-L1 inhibitor that's been studied in this particular setting. It's a relatively small study here, published in JCO in 2019, again, showing this differential expectation for efficacy in the MMR deficient patients versus the proficient patients here on the right-hand side. In this particular study, they were also controlled for POL-E. So again, responses seen in MMR deficient, but not in the proficient categories. And these are the progression-free and overall survival curves for these two cohorts. Now, probably the biggest story of recent has been lenvatinib and pembrolizumab. We've learned about this particular combination for some time. Lenvatinib is a multi-kinase inhibitor targeting anti-angiogenesis and other receptor kinases. This combination demonstrated some very early efficacy, and in this paper now published in 2019 in Lancet Oncology showed a high level of responses, 40%, in patients who had largely microsatellite stable tumors, which was very, very encouraging. Here's the investigator-assessed PFS showing a median progression-free survival of 7.4 months. And the duration of response, like we've seen in some of these other annotated tumors for MSI, very long duration of response. So this is very exciting to see for these patients who ultimately do get a response. Now we know that this drug does have toxicity. It does seem to be dose dependent. In this particular study, we saw factors such as hypertension, more GI side effects, and hand-foot syndrome, things that we would normally see with lenvatinib. We also saw some problems, as we'd seen before with single agent pembrolizumab, which made some of these adverse events a little more difficult or trickier to sort out. But definitely in the setting of high level of efficacy, makes evaluation of this as an important part of our armamentarium for patients with endometrial cancer. And of course, in this filing, which came in 2019, September, their FDA did approve this combination for patients with proficient mismatch repair tumors, or those that did not demonstrate MSI, who had had prior chemotherapy. So very important study. Now, what's really interesting about this study is that this combination was being evaluated against physician choice chemotherapy in that same setting. So we have the accelerated approval for the combination in MMR proficient patients. We compared that against chemotherapy in Keynote 775. And although we don't have the results of this trial, we did get a hint that it is going to be a blockbuster for us, because in December 16th, just a few weeks ago, there was a press release that said that this combination improved objective response, progression-free survival, and overall survival against chemotherapy. So we're anxiously awaiting the data for this particular study. Now, there's a large number of other trials that are ongoing. You can see the first one I've listed there is LEAP-001. This is actually looking at the combination of lenvatinib and pembrolizumab against frontline chemotherapy. This trial is obviously was taking on can we replace chemo in the very first line setting for metastatic and recurrent endometrial cancer. The others that I have listed to the right are all going to be chemotherapy add-on trials. So you can see all of those immune checkpoint inhibitors are being added to chemotherapy, with the exception of DOE, which is also looking at the addition of a PARP inhibitor, olaparib. Now, fortunately, we don't have a lot of time to go through all of these different pathways, but it's clear that they are very important to this disease. One of the ones I just want to highlight is the ERBB2 axis, for which we have a targeted drug, trastuzumab. This is a small randomized phase 2 trial looking at patients with uterine serous carcinomas that have overexpression or amplification of HER2/neu. And you can see what that frequency is and how it relates to the different histologies over here on the left-hand side of that box. But we did see an improvement in progression-free survival with a hazard ratio of 0.44. And when we looked at this both in primary and recurrent disease, the efficacy seemed to be even greater in patients that had advanced disease with a hazard ratio of 0.4. So a very exciting targeted approach for a select group of patients with serous cancers, which are, as you know, are very difficult to treat anyway. This is the overall survival, again, showing some merit to this, extending into further lines of therapy, but again, showing its activity strongest in patients who are initially treated. So this could be one of the newer avenues that we could pursue to try to look at an add-on to chemotherapy. Now, there's a lot of other pathways that I think are really of interest. I just wanted to quickly show these. As you know, the cell cycle has a number of checkpoints. P53 is frequently mutated in the serous carcinomas, as I just mentioned, and that puts a lot of strain and pressure on the WEE1, which is a distant cell cycle checkpoint. If it is inhibited, then cells with a high degree of genomic instability will then pass through this checkpoint and go into division and ultimately lead to cell death. And so WEE1 inhibitors have started to enter into the domain. This is a small study that was done to look at the efficacy of a WEE1 inhibitor called adavosertib. And you can see here that there were objective responses in this cohort of patients nearing 30%. Because of this, and as I mentioned, there's a lot of alterations in the homologous recombination and DNA damage response pathways. They're listed here in this, again, through the TCGA. And this has led to the design of a trial called GY012, which is looking at olaparib alone or in combination with a number of different agents, including anti-angiogenesis agent, an immune checkpoint inhibitor, and an AKT inhibitor. So this will be looking at ways to see if we can augment and take advantage of this, altered pathway within endometrial cancer. The last area I just wanted to focus on quickly is the cell cycle regulation through the cycling kinases. There's a lot of cross interaction between this and the endocrine pathways, as you well know, with breast cancer. These particular drugs are now making their way into endometrial cancer. They have all shown at least some level of efficacy as single agents in endometrial cancer, and there's a large amount of rationale that would support that given the pathways that I had mentioned. This year at ESMO, we had the first of the trials looking at the combination of palbociclib plus letrozole versus letrozole, again, following on previous trials that have been done in breast cancer. This particular trial was quite exciting because we did see a difference, almost a tripling of the median PFS, with a hazard ratio of 0.56 and a substantial number of patients who got disease control for 6 months or longer. Unfortunately, this is associated with more toxicity, as has been our experience in breast cancer. And so again, strategies to mitigate this will need to be sorted out as we go forward, but the efficacy is very promising. And you can see these drugs are now percolating their way through endometrial cancer development as well. There's a number of trials coming as they look at not only alone with chemotherapy, but also with other biological agents, as mentioned here. So it's a busy space. We're fortunate because of all these alterations, we have the opportunity to expand on our treatment outcomes. And so more to come in the very near future. So I think that, chemotherapy has probably reached a ceiling because we have a better understanding of the biological role of the different signaling pathways and alterations in this disease. It has exploded into a new arena of looking at novel single agents and combinations. Many of these areas now are under active development, and our hope is that we can redefine how we will approach this disease in the future. Thanks so much, and I appreciate your attention.